Okay, can everyone hear me okay?
Yes.
Good afternoon, everyone, and thank you for joining us for part 2 of Deconstructing SBIRT Coding and Billing webinar. My name is Laura Grendel, and I will be moderating this series. We have muted everyone's microphones for this presentation. However, question asking is encouraged. If you have a question, we ask that you add these to the comment field and they will be answered during the Q&A at the end of the presentation. It is now my pleasure to introduce Toni Elhoms. Mrs. Elhoms is a nationally known speaker and educator with credentials from AHIMA and the AAPC. She has expertise in both inpatient and outpatient coding, compliance, billing, and reimbursement. She has worked with hundreds of Title X and public health agencies and school-based health centers across the country. She leads and mentors a network of coders across the United States. Toni, I will now turn the presentation over to you.
Okay, great. Thank you everyone for joining us today. Happy Friday, and hopefully the last of this crazy snow weather. I'm very happy to present the final webinar as part of our web-based training series for the SBIRT and School-Based Health Center project. RT Welter is very excited to partner with the state to assist school-based health centers with implementing compliant SBIRT coding and billing practices. This project has encompassed many elements. The first element, I have met with many of you on site in your school-based health centers to provide hands-on training with regards to SBIRT coding and billing. That's been very exciting. I've enjoyed meeting all of you and seeing your wonderful organizations and the great things that you do with the community and for the community. So that has been one of my favorite parts of this project. Also, an electronic audit tool that will really serve as a framework for successful SBIRT implementation. These two web-based trainings that we've done, part 1 last month and then part 2 today, will both be accessible at our YouTube channel, which I'll provide the link at the very end of this presentation. And then if you have any questions, you can always reach out to Laura or myself. Post-training surveys. Your feedback is very important to us. If you would like to tell us anything about additional training needs or how we could do things better, we definitely would like your input. So those post-training surveys are very important that we collect that feedback. And then a training manual. So as part of this process, we have developed a guidance document, which will be released to you very soon. That will include all of the information that we've reviewed in part 1, as well as part 2, in addition to the electronic audit tool that we'll be reviewing today. As Laura said, we will take questions at the end of our session. So if you do have a question, please feel free to use the chat box. The overall goal of this project is to ensure that support staff as well as providers know how to utilize SBIRT codes for correct coding as well as reporting for SBIRT. And I really look at this as the 3 C's: coding, confidently, and compliantly. So having a very good understanding of how to implement SBIRT into your organization in the most compliant way. So we'll talk a little bit about what we reviewed in last session very briefly, and then we'll actually discuss the reimbursement tied to SBIRT. That's one of the questions that's come up often is, hey, do payers really recognize these codes? Are they actually reimbursed? So we're going to talk about that. We'll also take a look at the customized electronic audit tool that was designed exclusively for school-based health centers in this implementation process. Very excited about this tool, but I also want to preface the introduction of the tool with it is not in its final state. So if you have recommendations or feedback about how we could make this tool better, we're open to that, and we would love to hear your feedback. We'll also talk about some practical applications of the SBIRT services and really in layman's terms how this translates to your clinical practice. We'll also talk about the many SBIRT resources available to you and then some appropriate action items to take. So we talked about in our last session SBIRT, the definition of SBIRT, and exactly what is expected for SBIRT services. So screening, brief intervention, referral to treatment. SBIRT is essentially those components. So we're looking at assessing a patient for risky substance use or behaviors using a standardized screening tool. And then when it's appropriate, conducting a brief intervention to engage a patient that's showing risky substance use behaviors in a short conversation that may or may not include feedback and advice. And also referral to treatment. So making sure that you're coordinating a referral for brief therapy or additional treatment for any patients that screen for the need to have additional services. The ideal SBIRT workflow would be asking the 2 screening questions, which we talked about in part 1. Guiding the patient based on his or her response, which will be circumstantial and contingent on the patient, assessing the risk of the patient, providing advice and assistance, as well as continual support. So that continuity of care for the patient-specific needs. SBIRT services include alcohol and or substances other than tobacco abuse, structured screening, and brief intervention. I want to clarify something because I know in part 1 we talked about smoking cessation. Smoking cessation is not part of SBIRT. I've included smoking cessation codes so that you are aware of the options to report in the instance that you're dealing with any smoking cessation needs that would need to be addressed. But it's very important that everyone is on the same page about what SBIRT encompasses, and SBIRT includes alcohol and or other substances outside of tobacco screening and brief intervention. Smoking and tobacco cessation services, as I stated before, those are not designated SBIRT services. So I apologize if that was confusing at all. These 2 codes represent counseling visits that are greater than 3 minutes, up to 10 minutes, or greater than 10 minutes, and they're represented by these codes. These codes are reimbursed and can be billed according to the medical necessity for your patient. Alcohol and other substances, the screening and brief intervention codes are 99408 and 99409. These codes cannot be reported together. They're reported based on the total cumulative time for the encounter. So for example, if you spent 35 minutes with a patient on a structured screening and you provided brief intervention, you would only report CPT code 99409 because the 2 codes cannot be reported together. So 15 to 30 minutes would be reported with the 99408. Anything greater than 30 minutes would be reported with 99409. If you do not meet that minimum 15-minute threshold, then we'll be looking at the other option. So for Medicaid purposes only, I'm sure many of you have seen these codes, H0049 and H0050. Now, Colorado Medicaid has specific guidance with regards to the application of these codes. We are going to talk about that in this session, but if you have any specific questions pertaining to Medicaid billing for these codes, I'm going to direct you to their manual. So the definition of H0049 and how it should be reported is found on page 8 of the billing manual for HCPA, and I've included that resource so that you guys can see exactly what the literature states. I've also pulled some of that information for our presentation today. So when we look at the guidance from Medicaid for SBIRT services, they're stating that the components should include a standardized screening tool, providing feedback to the member based on their screening results, discussing negative consequences that occurred and the overall severity of the problem, motivational counseling towards behavioral change, a joint decision-making process regarding the substance or alcohol, and discussing and agreeing on plans for follow-up, so a treatment plan. There were many questions regarding who can provide SBIRT services. As it pertains to Colorado Medicaid, straight from their manual, they are stating ancillary staff, including health educators, may perform SBIRT services under the supervision of a credentialed provider, which means there would need to be a nurse practitioner, a PA, or an MD or a DO within the practice supervising while the ancillary provider is performing SBIRT services. The services should relate to a plan of care and will require billing under the supervising provider. So if the nurse practitioner is supervising the health educator that day, the health educator is rendering the service, the codes are still reported under the supervising physician, and the documentation should be signed and authenticated by the rendering provider if it's a health educator, as well as the supervising provider. SBIRT screening and brief intervention that does not meet the minimum 15-minute threshold is not separately reimbursable, meaning you cannot report a separate code if you don't hit that minimum 15-minute mark. They are strictly time-based codes, and start and stop time or the total face-to-face time is encouraged for appropriate and compliant clinical documentation. Procedure codes 99408 and 99409 may only be billed when all conditions are met. When a full screen is positive and the amount of time of the full screening, brief intervention, and referral to treatment meets the time threshold for the selected CPT code. Now keep in mind, I'm sure many of you are aware, the state fiscal year is July 1st through June 30th. So that is going to be the determining factor for coverage on these services. The full screen will frequently be negative, and the member will not require brief intervention or referral to treatment. These instances, according to Colorado Medicaid, are still reimbursable as it pertains to HCPCS code H0049. Now, I've received many questions about this code and the correct application of the code. Based on Colorado Medicaid's guidance as outlined here, they're stating that 1 unit of service can be reported when all of the conditions are met. So a positive pre-screen, a full screen that was negative, and a brief intervention or referral to treatment was not necessary. So that part of the service was not completed. Keep in mind, H0049 cannot be reported with 99408 or 99409 as they are inclusive. So it would need to be one or the other depending on the total time spent for the intervention. We'll talk about frequency and reimbursement in just a few minutes, but that information came directly from the Colorado Medicaid manual. So back to the SBIRT codes, the 99408, 99409. The intensity of the service is going to be determined by the total time spent in face-to-face counseling on the service. So 15 to 30 minutes is that first code, and then greater than 30 minutes for the second code. Clinical documentation elements. So we need to know the rendering provider, if they're eligible to actually render that service. The screening tool or the validated instrument that you use. to determine the patient's opinion towards behavior change. The documentation in your plan to demonstrate development of a patient-specific treatment plan to change behavior with appropriate actions and motivation. And then the total time spent in face-to-face counseling. These are all required clinical documentation elements. So I would recommend providers, if you're utilizing templates, take this information and make sure that it's in your template. The craft. This is a very small version of the structured screening tool that's being utilized by the majority of school-based health centers. So this information validates the requirement for a structured screening tool. This is what you need, this information to be completed by the patient and reviewed and verified by the provider. With the ICD-10 code, so we've talked about the CPT codes, we've talked about the clinical documentation elements. We also need to make sure that we're providing the appropriate ICD-10 code to reflect the most specificity that we have at that encounter. Now, diagnosis codes will change during the course of patient treatment. So if a patient is getting better, maybe they've de-escalated from abuse to dependence, or their type of use has changed. It's okay to update your codes based on the presentation of the patient and the development of the treatment plan, as well as how the diagnosis changes over the course of treatment. Now, the concepts that we talked about in part 1, we'll just briefly review, but all ICD-10 codes specific to SBIRT services are categorized based on use, abuse, and dependence. And there is a very specific hierarchy with the application of these codes. So if use and abuse are documented, we would only want to code for abuse. If abuse and dependence are documented, we would only want to report a code for dependence. Same thing for use, abuse, and dependence. Dependence will likely be the classification that you will assign most commonly. The term use provides a mechanism for code assignment when a provider indicates a patient's use of a substance, but does not further specify that it classifies as abuse or dependence. So this is the lowest classification on the spectrum. The term use is found at the bottom of the scale because it does not represent a definable measure of severity. Use does have sub-classifications as part of the ICD-10 clinical modification. So continuous use is classified based on the substance. So for example, drugs, that would be daily or almost daily use, and alcohol, that could be daily intake of large amounts of alcohol or heavy drinking on weekends or days off from work. These are just some examples. Episodic. This could be short periods between use or use on the weekend, alcohol binges that last weeks or months, followed by long periods of sobriety. Again, this is a subclassification of use. And then remission. Remission is a complete cessation of alcohol or drug intake for a period of time during which a decrease towards cessation is taking place. I apologize, there is a typo. Unspecified. This means that you don't have any additional information, so it's unknown to you. It is not appropriate to assign unspecified codes or classifications in the instance that you do know the information or have access to obtain that information. Abuse is indicated. Withdrawal symptoms are not likely to occur when use is discontinued and is separately defined for drugs and alcohol. And then dependence, which I stated will likely be the classification you will use the most, indicates in the provider's opinion a withdrawal symptom or symptom or syndrome are likely to occur when use is discontinued. So it's very important that the diagnosis code matches the service and it provides the most specificity that you have access to at that encounter. So now we'll go back to reimbursement and the specific reimbursement tied to these SBIRT codes. So when we look at the H0049, this is from the Medicaid manual, the billing manual, and it's stating that H0049 is covered up to 2 times per state fiscal year for full screens. That's coverage on 2 instances, 2 separate dates of service. And then for the 99408 and 99409, that's covered up to 2 sessions of brief intervention and referral per state fiscal year. So they do cover these services more than once in their fiscal year. They also go further to state that reimbursement for SBIRT services will be less than the established usual customary charge, as is with all services in alignment with Health First Colorado's allowable fee schedule. The other thing to keep in mind, and we'll talk about this a little bit more when we get into the practical applications, is that Colorado Medicaid will pay for separate services on the same day as SBIRT, so long as medical necessity is established. Medical necessity is established through thorough clinical documentation and specific ICD-10 coding. SBIRT codes cannot be separately reimbursed when billed under the mental health and substance use disorder screenings, which are represented by codes H002 and H004. So those codes may not be reported on the same day as SBIRT. As far as reimbursement for SBIRT, these reimbursements are the CMS reimbursements. So these are not specific to Colorado Medicaid. So it just gives you a ballpark. And then H0049, we have pulled the reimbursement from Medicaid. One of the questions that I'm asked all the time is, well, do they actually pay these codes? They do pay these codes. It's just very important that you justify medical necessity, have thorough clinical documentation to support the reporting, and the patient has not exhausted their benefits. So 99408, it looks like that is reimbursing at about $36 based on the CMS national average, and 99409 at about $70. So these are real codes, and they are actually reimbursed. I've also put the smoking cessation codes on here. Again, smoking cessation is not part of SBIRT, but I've gotten this question a few times. So the smoking cessation code, based on the CMS fee schedule, greater than 3 minutes up to 10 minutes, reimburses at $15 per session, and then $28 for greater than 10 minutes. So these are covered services. Now I'd like to turn to the electronic audit tool. This audit tool was specifically designed for school-based health centers to ensure capturing of all coding and clinical documentation elements to report SBIRT services compliantly. If you use this information, in addition to the training guidance document, in addition to the advisement that you receive during the on-site assessment, in addition to these web-based trainings, you will be successful. Feedback. We'd love to hear your feedback. If you think that we should make any changes to this document, we are open to that. Most of this information came from the CPT guidelines. So we're happy to make this user-friendly and incorporate any of your suggestions. The other important thing to consider is that this document was designed for electronic applications only. So if you print this out, you may not have a full picture of how to use it. Now, when we developed this tool, we really had the workflow in mind that this would be temporary until providers are acclimated to the process. Once providers get used to incorporating correct clinical documentation and assigning the codes, in addition to medical necessity, these tools may not be necessary because they'll be incorporated into the provider workflow. So I am going to actually pull up the physical document so we can see this together. So this tool is designed as a coding and auditing tool. As I said, this is likely going to be something you'll use for maybe the first few months while you're working with SBIRT, if you haven't started SBIRT, and then eventually you may not need to use this tool as much. So we are making some changes, but we would like to get your feedback after this web-based training on how or if we could do this any differently. So the information on this tool is really a reminder and a guide as to all of the required coding and clinical documentation elements for SBIRT. So time spent, that is the basis of determining these codes. So it's very important that we know the total time spent on SBIRT. The provider that rendered the service, if it's your health educator, we would need that information. We would also need the supervising provider's information in the instance that the nurse practitioner or the other eligible rendering providers directly provided the service or supervised the service. Your documentation would need to be very clear. The substance or substances, if there are multiple, we would need to know that information. And then the SBIRT codes. So we'll be making a couple of changes because I can see how this is a little confusing, but alcohol and or substances are going to be on our left side. This is our 99408, 99409 with the brief description as well as some notations about when you would not report the service. Now I know it states on here that 99408 and 99409 are only used for initial screening and brief intervention. We will be removing the initial because that is not an accurate picture of the coverage. As we know, they cover up to 2. So we'll take that verbiage out. The other thing that I would like your input on is if you like having smoking and tobacco use cessation on this tool. If you think that it's confusing, please let us know. These are not considered SBIRT codes. We put them on here because of the similarity in relation to addressing alcohol and or other substances. We also have a notation about the Medicaid specific codes. Now keep in mind, these are specific to Medicaid, and H0050 is an unpaid benefit. So you're welcome to report it, but it does not get reimbursed by Colorado Medicaid. Now I'll refer you back to the rules specific to Colorado Medicaid for the H application codes. Then we go down to the middle section, which focuses on our ICD-10 code selection. You may have more than one ICD-10 code. That is perfectly fine. Patterns of use, you have a drop-down menu that then goes to further classify use, abuse, and dependence. And then it talks about the definitions of use, which we talked about, the subclassification. We also have a hierarchy on this document. So it tells you in the instance that you have use and abuse, you would code for abuse, and so on. The second side of this document is all about the clinical documentation. Provided intervention. So as part of the behavioral change, we would need to see interventions specific to the patient. This will not look the same for every patient, but we should see things like readiness for change, behavior change, barriers to change, motivational counseling, any suggestions on actions to be taken, or arrangements for follow-up. We'd also like to see in your documentation patient's progress, if they're responding to treatment, if there are any revisions in the clinical diagnosis, as well as rationale if you're ordering any additional services, a clear assessment, clinical impression, and diagnoses. date and legibility of the provider, both the rendering and the supervising provider, any appropriate physical exam findings or diagnostic tests, a clear plan of care, as well as reason for encounter, appropriate relevant history, health risk factors, and documentation to support all of the individual components of each CPT code. Per the Evaluation and Management Guidelines, which encompasses this section of code, the above elements should be used in accordance with good documentation practices. So this tool provides the ICD-10 guidance, the clinical documentation guidance, as well as the CPT codes guidance. We've also included the information as it pertains to the AMA's 5 A's model. So that's the ask, advise, assist, arrange methodology. And this is the stuff that we're really looking for to be embedded in your clinical documentation. So this is the audit tool. As I stated previously, it's designed for electronic audit application. So please let us know after this webinar on your post-training survey results or in an email, however you see best, how we can make this e-tool better. Practical applications. So the next question you're probably wondering is, when am I going to be able to report SBIRT services? When does this opportunity come up? Well, you could look for reporting SBIRT at a well child check when they're there for their annual visit. If they come in for an acute visit, whether that's related or unrelated, as well as follow-up visits for other conditions. It can also be reported as a standalone service. So you would not need to bill an office visit in addition to SBIRT in order to report SBIRT. SBIRT can be reported as a standalone service with appropriate clinical documentation and medical necessity. SBIRT should not be reported with behavioral and health assessment. So I put the specific CPT code 96150 and 96155. Anything within that range cannot be reported with SBIRT on the same claim. The reason being is because they're considered mutually exclusive. So these code pairings will automatically be denied by an insurance company. SBIRT services should not be reported with health risk assessment. So the CPT codes 96160 and 96161. These codes are also considered mutually exclusive. So if you're billing for these codes on the same day as SBIRT, you may receive a kickback. So as far as next steps and action items, I would encourage you to utilize the electronic audit tool. This tool was specifically designed for you to successfully implement SBIRT services. Also, utilize the upcoming training manual. This document will have all of the information that we've discussed in our web-based trainings, in addition to the electronic audit tool, as well as some other helpful reminders. This guidance document will probably be pretty lengthy, so if you don't have a lot of spare time, perhaps the web-based trainings would be most sufficient to get the information that you need. Implement SBIRT coding and billing workflows. So the providers as well as support staff will need to really think about how to successfully implement this into your organization. It may require some modifications in workflows, as well as modifications in templates, as well as modifications in support staff workflow, and how we can make everyone work together in a seamless process to ensure compliant coding and billing for SBIRT. You're always welcome to refer back to these recorded webinars. They will be on our YouTube channel. We'd also like to hear your thoughts about additional training needs or things that we could do better. So please fill out the post-training survey and send that back to Laura. If you're feeling overwhelmed at any point in this process, remember our main goal, the 3 C's, coding confidently and compliantly. And this applies to anything coding related, not just SBIRT. Some resources. So rtwelter.com, that's our website that has a plethora of resources, as well as our YouTube channel. The YouTube channel will have the web-based recordings, and you will be able to access those whenever is best for you. SAMHSA also has incredible resources. I've taken many of their resources from their SBIRT manuals and included those in these webinars as well as the training guidance document. The other great resource is the SBIRT Colorado Medicaid Billing Manual. So looking at that specific to SBIRT will give you the guidance from Colorado Medicaid and the appropriate applications for SBIRT services specific to Colorado Medicaid. At this time, I'm happy to take any questions that you may have.
Toni, before I unmute everyone, we did have one question come over the chat while you were speaking, and it's from ProPlus, so I'm not sure who that is. But they asked, do you need modifier 25 if billing E&M code with SBIRT service?
That is an excellent question. So you would need to utilize modifier 25 if you are reporting SBIRT services on the same day as a evaluation and management service. Now the key here is compliance with modifier 25 application. So oftentimes individuals that are applying modifiers that do not have all of the tools and resources have a misunderstanding of when it's appropriate to utilize modifier 25. Modifier 25 indicates that there is a significant and separately identifiable evaluation and management service on the same day as another service. And that could be a procedure, that could be SBIRT. So the documentation must support 2 separate encounters because you're reporting 2 separate codes.
Great, thank you. I've gone ahead and unmuted everyone, so if you do have a question to ask, you may do that at this time. All right, Toni, I don't think we have any additional questions, I guess.
Okay, great. Well, thank you everyone for attending. We really appreciate your time and we hope you have an excellent weekend.
Thank you again, everyone. Please keep an eye out on your emails. We'll be sending out the post-training survey for everyone to fill out, and we do ask, it is very important for us if you fill that out. So please go ahead and do that and check in on our YouTube channel in the next day or 2, and we'll have a copy of this recording up then. Thank you all so much and have a great weekend.